Good morning, good afternoon, and good evening, all. This is Murat. I'm a hepatitis virus consultant based in the Ministry of Health, Ethiopia. I'm seconded by AFNET in collaboration with the US CDC. I will present the Ethiopia's initial experience on hepatitis virus pilot implementation. Having said that, I want to highlight some of the basic information, the country basic information. Ethiopia has a population of close to 103 million. I think this country, Ethiopia, is the second populous country in Africa next to Nigeria. Of this population, around 3.5 million is estimated of live births, which is 3.36% of the total population. The estimated surviving infant is 3.25 million, which is 3.16% of the total population. The proportion in skilled births in the country is estimated around 50%, which ranges from 26% in Somali region to 96% in Addis Ababa. With regard to the seroprevalence in different population groups, the estimated prevalence in the general population is around 7.4, and in among pregnant women it is estimated around 4.7, and in among the children under 5 years it is 4.4%. Which is this according to this information, we can conclude that Ethiopia is considered to have intermediate to high prevalence of hepatitis B virus infection. To see the hepatitis birth dose vaccination coverage in Ethiopia, no hepatitis birth dose vaccination service so far in Ethiopia actually, except the pilot implementation that we are starting to go through. The infant hepatitis B vaccine was added to EPI series in 2007. The current 3 doses of pentavalent B vaccine, as a schedule is at the age of 6, 10, and 14 weeks. This is an ideal schedule for Ethiopia. The estimated coverage level, according to Ethiopian Demographic Health Survey to 2019, is the Penta 1 is around 76%. The Penta 3, the third dose, is around 61%. With including this, the BCG coverage rate is estimated around 76%. So this is we can understand that this coverage level is really suboptimal to ensure the population herd immunity. This slide shows the distribution of hepatitis B infection and pentavalent 3 coverage. So I think we have around 11 sub-regions here. So when we look across the regions and across the setup, rural urban, so most of the regions here showed that they are under the high burden, and then some of the regions are like in the intermediate burden. So we can understand that at national and sub-national level, the burden of hepatitis infection is really very high in most of the sub-regions. And then generally we can conclude that it is the countries in the intermediate and high level, high burden of hepatitis B infection. So according to this steady finding, the national prevalence was estimated around 9.4%. So this is actually, we cannot definitely link, but the pentavalent vaccination coverage by region shows this. Unfortunately, if we look, unfortunately or fortunately, the Afar vaccination coverage is around 26%. When we look at the hepatitis B infection rate, it is really, it looks a linkage, I think, even though it is, because this is a factor, one of the risk factors for the hepatitis B infection. So even though in most of the regions, the coverage of the pentavalent vaccination service, which includes the hepatitis B vaccination, infant hepatitis B vaccination, in most of the regions is less than 80%. So that is the key message from this graph. It has many messages that you can see and interpret from your perspective. With regard to the existing guidelines and strategies in the country, the Ethiopia has a national strategic plan and guideline on prevention and control of hepatitis, viral hepatitis. It was developed in 2016 and served up to 2020. These documents are under revision currently for the hepatitis prevention and control. We have a guideline, and Ethiopia has a guideline on the screening and treatment of pregnant women. The pregnant women are under high risk groups based on the status if they are positive. So there is a guideline for treatment of the pregnant women is available, even though the actual practice has many drawbacks and which need further assessment to say exploratively. We can conclude that the country has guidelines, the necessary guidelines and strategies in place, and it needs to work on the actual practice in the ground. As I have said earlier, Ethiopia has started the pilot implementation a few months back. I want to tell you what activities we had done prior to the start of the hepatitis B piloting. In our comprehensive multi-year plan of EPI from 2016 to 2020, we had indicated that hepatitis will be introduced to be introduced in 2018, but unfortunately it was not realized at that year. Since August 2017, the Ethiopian National Immunization Technical Advisory Group had initiated discussion on the national hepatitis first dose introduction, following the request from the Minister of Health. We have a research advisory group which serves to generate evidence for the maternal and child health services in the country. This council had generated an evidence on economic evaluation on the introduction of hepatitis B to introduce in the immunization program in Ethiopia. The finding was really very supportive for the introduction. The incremental cost effectiveness ratio showed a USD of 110 per days averted. So for the further read, I think the link is indicated there. The Ministry of Health and the stakeholders following these evidences, based on the above evidences that I have talked more, had developed a policy brief and concept note on the piloting. Initially, we were discussing to start it on the urban setups, but later we just agreed to include all the combination of the setups from the country. After then, the detailed proposal developed and shared with key stakeholders, and then budget mobilization was done. Pilot site was selected, and all the sites were informed properly. The necessary preparations, including the capacity building and social mobilization activities, are done. And then now the pilot implementation is really underway, as I have said earlier. So this is the objectives that were indicated in the concept note to identify and address programmatic and logistical challenges and barriers during the vaccination, to test the strategy, and then draw lessons learned and document best practices to inform for the scale up of the hepatitis first dose introduction. Thirdly, it was said to determine the hepatitis vaccination acceptance by different target groups like the healthcare workers, caretakers, and other relevant beneficiaries and influencers. Fourthly, it's set here to estimate the hepatitis first dose vaccination coverage, both timely and late vaccination coverage. In Ethiopia, we said that timely hepatitis first dose coverage if it is provided within 24 hours, and then if it is provided after 24 hours, up to 14 days, it is labeled as late coverage. fifth, it was set to determine the impact and effectiveness of hepatitis birth dose in averting hepatitis infection rate. Last but not least, it is included to determine the cost and cost effectiveness of the pilot introduction, just to get substantial insight for the full-scale nationwide universal hepatitis birth dose introduction. These are the objectives of the pilot introduction in Ethiopia. With regard to the designs indicated in the pilot introduction, it is to redesign a new vaccine delivery point, because usually the vaccination service in Ethiopia is provided in vaccination rooms. In case of this birth dose, we need to establish the service delivery point in delivery and PNC units. And then there is a task shifting and sharing will be in place, and it is in place now. Vaccine logistics, training, and linkage between the integration as well as the coordination among maternal, child health, and vaccination services need to be ensured. With regard to the setting, as I have said earlier, we have three settings in Ethiopia: urban, agrarian, and pastoral. So the pilot is already implemented, has been implementing in all these three settings. In terms of the health facility levels, all types of health facility level, hospital, health center, and health post. This health post is operating by health extension workers in Ethiopia, and even including the outreach and the mobile sites are included in the pilot implementation. The others, like pregnancy and birth notification, institutional delivery, increasing institutional delivery, reaching home births to attain and sustain high hepatitis B birth dose vaccination, is included as methods and designs of the pilot implementation, which is already underway to translate into reality. What I want to show from this slide is just 4 regions are included in the pilot implementation, one from urban and one from pastoral, and the 2 are from agrarian. We had using scores based on these 4 indicators. The indicators that were included for the selection criteria was antenatal care coverage level, the skilled birth attendant coverage level, a postnatal care, especially the PNC within 2 days coverage level, as well as seroprevalency of the infection was included. The weights we had given is indicated here. The first three indicators were containing 20% each, and then the seroprevalence status was given 40%. Based on this, Addis Ababa, Tigray, Afar, and Amhara were selected out of the 11 regions that we have in country. So Addis Ababa is from the urban setup, Tigray and Amhara is from the agrarian setup, and Afar is from the pastoral setup. You can see the detailed rates every region has got from that competitive selection criteria. With regard to the relevant information on the pilot introduction, we have developed the recording and reporting tools, as well as training materials on hepatitis birth dose pilot implementation. So all these recording and reporting tools, as well as training materials, are prepared and shared with all the pilot sites, including vaccination. They will be available in vaccination, delivery, and NICU delivery points. Sorry. With regard to the IEC materials, information, education, and communication, fact sheet, brochure, and poster were prepared, as well as provided to all sites. This is the initial performance from 2 districts, as it is displayed in the table. You can understand that Amhara Goncha district we had started on the month of January, and Addis Ababa was started on February 2021. So the coverage level, the facility delivery, the home delivery, and you can see the vaccinated within 24 hours, and as well as for hours up to 14 days. All of capturing the newborns and providing the vaccination services. For example, in Amhara, it's already the newborns who have born at home. Some of the newborns are getting on lately time. So all the health facility, all the newborns who have born at the health facility are getting almost the on timely immunization services. Whereas in Addis Ababa, even though there is no home delivery reported, on the month of February it was around 60%, but on the month of March, almost most of all of the newborns who have almost nearly all of the newborns had getting the birth dose vaccination services. With regard to the challenge during the introduction, even the place of birth is really one of the challenge, as we have seen from the initial performance data. Low facility delivery or high home delivery is one of the challenge, especially for the agrarian setups. Socio-cultural factors. Home deliveries in Ethiopia, there is a practice of stay at home for 45 days after delivery. If mothers have given birth at home, there is a rare practice to visit health facilities. This is really one of the challenges to address hepatitis birth dose introduction. Thirdly, there is additional cost. This is very obvious that cold chain equipment, equipping cold chains and training, providing training for the delivery and postnatal or neonatal intensive care unit staff is requiring a cost. The time factor is one of the challenge, as we have providing the service within 24 hours is an ideal recommendation to adhere, the WHO recommendation, but unfortunately, it is very tough to get the newborns, especially who are born at home. So this is one of the challenges. The strategy is new, as I have said earlier, establishing and strengthening new vaccination service delivery point and providing the service within 24 hours of birth to all newborns, regardless of the place of birth, is not an easy task. These are the challenge, some of the challenges that we have in place. With regard to the opportunities of the introduction, the pilot implementation, as well as even the birth dose introduction, it is very obvious that hepatitis elimination is getting a focus at national, even at global level. This effort is already included in the SCDG. Funding and HA support is available for this pilot implementation. Planning to generate local data from this pilot implementation to inform the full scale introduction is another opportunity, another golden opportunity that we have cited here. There is even a promising possibility of getting additional funding and TA support from stakeholders and partners for the full-scale universal hepatitis birth dose introduction. On the next steps, I think effective use of technical working groups will matter to generate many important inputs, and this documenting all those discussions and tabling to the Ethiopian National Immunization Technical Advisory Group will be needed. Support, follow up, monitor, and evaluate the hepatitis pilot implementation will be our tight task, because it will stay for a year. So we have already tested for 2 to 3 months. Actually, the 3 out of the 4 districts have started on February. So we will remain with 10 and around 9 to 10 months to do this task. Engaging and collecting the best lessons and experiences from other low and middle income countries on top of the generating the data from the pilot implementation is another activity that we will engage. Engaging the Ethiopian National Immunization Technical Advisor Group to undertake a rigorous review of the evidence from the pilot implementation and the other evidence sources will be vital to draw an independent recommendations. This NITAG is very responsible to come up with technical guidances for the ministry, and then the ministry will call the members of inter-coordinating committee. This inter-coordinating committee is a member of all partner heads, chairing by the Minister of Health, the State Minister, and then this ICC will discuss and make final decision on the national universal introduction, hepatitis birth dose introduction. In case this ICC make decisions, and then following this resource mobilization and application for Gavi support and other supports will be the next task that we are expecting. As a country, on behalf of the country, I want to call for networking, collaboration, and action, because this networking and collaboration matters to translate the targets of hepatitis elimination into realities, including ensuring high timely hepatitis birth dose and the required consecutive 2 to 3 doses coverage in countries based on the WHO recommendation. Then Ethiopia is very open to collaborate, network, and receive any supporters for the full-scale universal hepatitis birth dose introduction, as well as overall hepatitis prevention, control, and elimination efforts. So finally, last but not least, I want to say that let us join our sets of various resources to translate the national and global targets into reality for hepatitis elimination by 2030. I think, as we all know, we have a tough target to reduce the chronic hepatitis virus infection prevalence to a level less than 0.1%. So I think this needs our joint effort to realize within the set timeline. This is over. Thank you so much.